or as I like to refer to it, a Myasthenia Gravis warrior, because we are fighting the fight against this disease. I was first diagnosed March 2020, the day before the pandemic shut down the country with COVID. I had previously been exhibiting symptoms from MG for several years without being diagnosed, seeing several doctors, having many tests run, MRIs, EMGs, all the things, without ever having anyone identify what was happening. I was told that all the tests that were being ran were coming back normal, and that there weren't seeing any issues with what was going on, which was completely contradictory to the things that I was feeling and what I was exhibiting. I had experienced several falls during that time previous to being diagnosed, falling and injuring my leg, chipping one of my teeth. It was just no explanations to be had. Eventually, and that I think was, of course, one of the hardest parts of dealing with it, was going through all of this testing and not being told that there was nothing wrong, even though I knew that there was. And also at times feeling unheard by doctors and feeling like I was just being pushed to the side or dismissed, because from what they could see, there was nothing wrong, but I didn't feel like what I was feeling was being considered. I was eventually diagnosed after going to a functional medicine doctor who ran an extensive panel of testing, and MG came up as a possibility, and I had to go back to my neurologist at the time to have him rerun the testing to confirm. However, in the process of doing that, I was automatically told, oh, it couldn't be myasthenia because you're not exhibiting this, this, and this. And as we all know, as MG patients, everyone does not exhibit the same with myasthenia gravis. Eventually, I did have the test reran, and the doctor that was overseeing my testing was the one who officially diagnosed me with MG and became my primary neurologist. How was I coping with this disease? So in addition to finally being diagnosed, I was now dealing with being locked down from a pandemic that nobody had answers to. Nobody knew at the time how, what to do with, or how to avoid catching COVID besides just isolating. And that was a bit of a struggle for me, being that I lived by myself. However, it was a relief knowing that I finally had words and a name to put to what my body had been exhibiting for so long. So it was lots of highs and lows. The ways how that I was able to cope with those highs and lows, first and foremost, was through therapy. I had started seeing a therapist a few months prior, also helping me deal with not knowing what was happening, but now I knew what was happening, and now being overwhelmed by that. So being able to talk through those issues and all the emotions that I was feeling, as I had been struggling with those things for a long time prior to being undiagnosed. In addition to therapy, I found support groups, and I started attending support groups. That was extremely helpful for me, because I was able to connect with people that had gone through or were going through or caring for people with this disease that I had officially have. And it was a sense of like community that I don't think that I could have found anywhere else. Being able to talk to people that understood what I was going through, understood what I had went through, and just somebody to say, no, you're not crazy. You were not crazy. That it was just a extreme help and relief. invaluable. And I was able to make many friends through through the process. Um, Now I think that I definitely found a new sense of confidence in the process as well. So after my first year of being diagnosed, in year 2 of being diagnosed, I came across the MGFA walk, and I was really excited for the 2021 walk to participate, to raise money and awareness for this disease and finding a cure, but also to finally probably meet some people in person who also had myasthenia gravis. However, unfortunately, due to the pandemic, the in-person walk had to be canceled, but there was still the fundraising aspect and then the celebration, end of year celebration that was going to happen. I was still excited for. So with the assistance of one of my cousins who was my cheerleader throughout the process, I created my campaign and I started fundraising and did way better than I thought that I could have even imagined at the time. But in the process of doing that, it really helped me find my voice to be able to speak out about MG, share my story, what I had experienced. I was still going through and learning, and helping me to inform my friends and family about this disease. Because prior to, I had been silent about it. I had been struggling in silence pre-diagnosis. I was silent about it in the early phases of being diagnosed. And now it was time for me to share what was happening. And so that's what I did. I shared my story, and it opened up a different door for me to be an advocate for MG, but also have my friends and family support me. It gave my mother some reassurance because when I was initially diagnosed, she struggled, me being her only child and her not being able to get to me and help me through what I was going through at the time. In addition to that, it helped my family, friends and family learn more about this disease, to be able to speak to it themselves. Some of them even did additional research on their own, which was very heartwarming, but also helping educate them on not just the disease on a whole, but how to help me, whether it be in day to day, just having more informative check-ins and not just checking in to check in. And it was not, more overwhelming for me than more of a relief for me. But also knowing what to do if I'm in crisis, or if they're with me and I have a fall or something happens, knowing how to handle that aspect of things. It made It I don't even know. I don't really have words to say, but it was, and it made things feel really different. But through that year of fundraising and advocacy, it I've just gained I guess, found my new therapy. So not only on medication for MG and doing treatment that way, but this was like a natural treatment for me where I can feel empowered, know that hopefully what I'm doing now will educate others and prevent someone from struggling with being undiagnosed for as long as some of us have, or so getting to a diagnosis quicker, or hopefully, continue to pave the way for new medications and hopefully for one day for an actual cure to this disease. So I will wrap this up with saying, some recommendations that I will have for you all or for you to share with others is definitely to try to get more involved if you're already involved, but get involved with the MG community. Join support groups. They're extremely helpful. There are so many in different, now there's so many in different specialties as well. So get involved, join multiple support groups, try to get, attend as many as you can or as few as you can, whatever you're comfortable with. Try maybe doing some fundraising and advocacy, sharing your story, whether it be to one person or to the masses, trying to share your story in whatever capacity that you feel comfortable with, whether it's friends and family, on social media. You never know the impact that you will have by sharing your journey with this disease and diagnoses to others. Volunteer with MGFA. We have some health fairs coming up. See where the closest health fair to you is. Consider attending, but also consider volunteering. And just getting to help others with myasthenia gravis get through and get information that they need to help them feel and hopefully get better. No, we can't get cured, but as close as we possibly can. Definitely listen to your body. I think that is one of the biggest things that I've struggled with and still working on, but doing much better at, is listening to my body, listening to, if I'm not feeling good, don't push myself. If I need to stay in bed all day, it's okay. Whatever the case is for you, just listen to your body, listen to your mind, listen to what your being is telling you. And last but not least, be your own advocate. Do not, doctors know what they know. Nurses know what they know, other medical professionals and other individuals, or just people in general, will always have input. But at the end of the day, you are the only person who knows what you're going through, how you're feeling, and what you need. And so be your own advocate. If somebody is telling you no to something and you feel like it might be beneficial for you, do what you need to do to get what you need. Make sure that you have a great care team that you trust and that you feel empowered with sharing and going on this journey with you, because that is what it truly is. They are on a journey with you in battling this disease and figuring out the best treatment options and what is going to make you feel the best that you possibly can and prevent you from having any flares or crises. So I hope that this little information was helpful. I hope to be able to meet some of you. If you see me at the conference, please stop me, say hello, introduce yourselves. I'd love to meet as many other MGers as possible. And I thank you to the MGFA for giving me this opportunity to share my story, and hopefully it is helpful. Thank you. Bye.
Hi, everyone. We're going to get started here in just a few moments. If you could just take your seats. I'm just giving people time to take their seats. I feel like she goes up there and then she stands there at the podium. Thank you. I hope that you, excuse me, I hope that you all had a good lunch. And I hope that you're really enjoying yourselves at the conference. The sessions have been, in my opinion, the sessions have been absolutely fantastic. And if I haven't said it before, I certainly want to thank all of the folks who have agreed to be speakers at this conference. Actually, can we just give all the speakers a round of applause? So before I make the introduction, I do just want to share with you all that we recognize that this is going to be a longer afternoon in order for us to stay on schedule and to wrap up around 4:30. That's our intention. Please, for what it's worth, please feel free to take breaks. Take care of yourselves first and foremost to manage your own health and well-being. Certainly, we want that to be top of mind for you, and I'm sure it is, but we just wanted to say that so that you don't feel that you're missing out on anything. It's going to be a long afternoon from here on out, so definitely take a break and take care of yourself. We'll wrap up around 4:30. We'll have a 2-hour break. We'll come together again at 6:30 for our get together. And it's going to be a Mardi Gras theme. And that's all I can share with you, but it's going to be great. Okay. So now I have the distinct pleasure of introducing Kimberly Moran, who's with UCB, and she's actually head of UCB's rare disease organization. And before I bring Kimberly up, I just want to share that UCB sponsored this luncheon. We wanted to share that with you before lunch, but the microphone was actually turned off in full transparency. So we want to thank UCB. They're such a wonderful partner and we just love working with their team. So Kimberly, why don't you come up here and say a few words? Yes.
Well, my job definitely got a lot easier because I was going to have the speech before lunch. Now I have the after lunch one, which doesn't make it that much easier because most of you have probably eaten and you're a little tired. So don't worry, these will be short remarks. First and foremost, I want to say thank you. Thank you to MGFA and our partnership for inviting UCB here. It really is wonderful to see the content, the interactions, and our commitment to myasthenia gravis. I think you can feel my gratitude. Just being able to sit at the table and truly partner and co-create with everyone in this room. I'm here to tell you that UCB puts patients at the heart of everything that we do. How does that happen? We listen. So I listen to many of you in the room. We have interactions with our patient panels. It's our job to listen. And what we hear is that myasthenia gravis is unpredictable. That's a hard journey that each and every one of you are on. Many of you have told me that you experience this condition in very, very personal ways that creates that profound uncertainty. Myasthenia gravis never rests, and here at UCB, neither will we. I also learned today from listening to many of you of everyday moments that sometimes create misses, from missing a time with your family to cook, missing that time to play with your kids, missing that ability to have the conversation. I've been so inspired by many of you and the ways that you've overcome these challenges in many moments of your disease journey, how you've demonstrated strength, empowerment, resilience. MG being a rare disease, I know many of you may wonder if your rare condition affects too few people for anyone to care. We care. We care not only about the physiological toll of MG, but also the mental toll it takes on the entire community. We're focused not only on the patient component, but also the community component. It's not only you living as an individual, it's your loved ones, your friends, your family, and your caregivers. And to be able to tackle what seems insurmountable, it's really about bringing the community together, to partnering to support the community. And it's really in these kinds of collaborations that are going to allow us to be successful as a group. We want to partner with you, with this community, and create programs that the community actually wants. So again, it is our job to listen to your needs, and to amplify those to improve care for the overall community. UCB's mission in MG is to develop unique solutions that can potentially improve outcomes for people living with rare conditions. UCB's approach to innovation and partnership informs not just our treatments, but also to our wider contributions to care and to support. That's why we are deeply supportive and work with advocacy groups across the globe, like the Myasthenia Gravis Foundation of America. And this gives us unique ways to jointly tackle the burdens of living with MG. We are so grateful to be here, and thank you.
I get to be the third person to welcome you back from lunch. So welcome back from lunch. Also, I'd like to welcome back all those that are streaming today on Zoom. We want to recognize and apologize for a little technical difficulty earlier today, but we will keep you plugged in all afternoon. So this afternoon, I have the pleasure of introducing our speaker on the management of acute exacerbation. Dr. Ashley Anderson is a neuromuscular specialist at Houston Methodist Hospital. She is committed to providing patients with comprehensive, compassionate, and evidence-based care that fosters an environment of open communication and partnership. It's with this foundation that she believes that allows for the formation of a personalized therapeutic approach that focuses not only on treating disease, but also improving the quality of life for the patient. Dr. Anderson has spoken at our Houston Regional Conference and as part of our Partners in MG Care Network. She was so outstanding this morning on this morning's panel that we brought her back this afternoon. So please join me in welcoming back Dr. Ashley Anderson.
Good afternoon, everyone. Thank you so much for having me again this afternoon. I'm coming here to talk with you about something that I hope none of you ever have to experience. And for those who have experienced it, that hopefully you'll never have to experience it again. Unfortunately, it is a part of what we need to discuss with myasthenia gravis. As was previously mentioned, it is unpredictable. And so exacerbations are common, but hopefully through this talk, learn different strategies in order to prevent and how to better navigate in case it does occur. These are my disclosures. So today in this talk, we're going to talk about, I'm going to give a brief introduction into myasthenia gravis, talk about different definitions, symptoms, and risk factors associated with an exacerbation, talk about outpatient management as well as inpatient management of a MG exacerbation, and then what things are available in order to prevent as we know, if possible. Not all are preventable, but there are some steps that can be undertaken. So these are slides that you may have seen before when talking about the history of myasthenia gravis. But the first description we think was made by Dr. Thomas Willis, in which he talked about a prudent and honest woman who for many years had been afflicted with these spurious palsies, as he called them, into which she could speak freely and readily enough, but then would become mute as a fish. And she was not able to speak a word until she was able to rest an hour or more. Okay. Unfortunately, after that, it was about 200 years later when Dr. Sam Wilkes actually described it more thoroughly in patients that he was seeing with more what we call bulbar, so your kind of speech and respiratory issue palsies as well. And then it was officially named by Dr. Frederick Jolly in 1895. So myasthenia meaning muscle and weakness, and gravis meaning heavy or grievous. And the one thing that I hope that you have been able to get from this conference, and especially from the presentation earlier, is that myasthenia does not have to be heavy and grievous like it was when it was described hundreds of years ago. And we talked about that 200-year break actually between the 1600s when Dr. Willis talked about it and the 1800s when Dr. Wilkes talked about it again in the naming of it. But as we can see, this is a busy slide and not for you necessarily to read, but to see that that kind of gap has not occurred again. The research and activity is very active and aggressive in regards to finding different management approaches and treatments and other discoveries for myasthenia gravis. So briefly, we talked about how rare this is, and actual incidence and prevalence or actual number of cases are hard to really get full data on, but it's estimated to be about 10 to 20 cases per 100,000 people. There is an age distribution. Usually there's a peak around 30 years old, and then another peak in diagnosis around 50 years old. For the younger patients, these are usually more commonly female. And then when we talk about myasthenia gravis as well, as many of you know, we can break it down as well into other categories. So we have ocular versus generalized. So ocular, eye symptoms, eyelid droop, blurry vision, double vision, and then generalized. So in addition to ocular symptoms, also having muscle weakness, speech changes, swallowing changes, etc. Now, the vast majority of patients, or a good portion of patients, will have purely ocular symptoms at the onset. But usually within the first 2 to 3 years, a good proportion of those as well will then become generalized. When we talk about also categorizing myasthenia gravis patients, we think about whether they're antibody positive versus what we call seronegative or antibody negative. Now, I just want to make a distinction. Just because somebody says that you're seronegative or antibody negative does not mean that you do not have an antibody that is causing your myasthenia gravis. It just means we have not been able to discover it yet. There are multiple proteins associated with the neuromuscular junction, and different antibodies have been discovered related to those. Most recently, the last one there, LRP4, with lipoprotein related protein 4 antibody. So we're still discovering the different antibodies that we can actually call these patients antibody positive. But as you can see there, the vast majority, about 80 to 85%, are acetylcholine receptor antibody positive. Then we have about 5 to 7%, which are MuSK or muscle specific kinase positive. And then the last one, 1 to 2% in that LRP4. And then lastly, early versus late onset myasthenia gravis. Early means that the patient was diagnosed when they were less than 50 years old, and older when they were greater than 50 years old. There are some variations in what people think that may make on as far as the disease course. For patients who are earlier onset, they believe this may have a more aggressive form of the disease. But for those patients who are more late onset, certain medical comorbidities that may have come with age may have more impact on disease as well as treatment choices. So when we talk about exactly what is an exacerbation, what is a crisis, We just want to talk about specifically what we mean there, what to look out for, and some certain things in regards to risk factors. So a myasthenia gravis exacerbation is a worsening of any MG symptom or symptoms. It can range in severity to being very minimal, and it can be very moderate to severe. And that can mean worsening eyelid droop, worsening speech, worsening swallow or weakness. When we talk about a crisis, this is specifically meaning that there's a severe exacerbation to the point to where there's respiratory failure that you require ventilatory support. So sometimes that means intubation or hopefully non-invasive ventilation like a BiPAP, which we'll talk about a little bit later. So about at least 70% of patients or so will experience an exacerbation at some point during the course of their disease. However, a crisis itself occurs in about 15% of patients. Now, typically, this is in the first 2 years after symptom onset. For some patients, a small minority, it may be the initial presentation. However, the good news here is that the majority of patients who suffer a crisis will make a full recovery. There are certain complications to be aware of, including complications that come with intubation, infection, and also cardiac complications that can occur as a result of a crisis. So we also want to talk about who is more at risk. So when we talk about certain types of patient characteristics who may be more at risk for having an exacerbation, these are patients who are at an older age. Again, we're talking about some interplay here with other comorbidities. Patients who are diagnosed with later onset myasthenia gravis. Those who have a higher Myasthenia Gravis Foundation of America or MGFA class, and we'll see on the next slide exactly what that means. And then those with other medical comorbidities, including other autoimmune conditions. This was a study at the bottom here with some information that was looking at certain types of prognostic factors for exacerbation. EOMG means early onset myasthenia gravis, LOMG late onset, and AID is autoimmune disease. So as we can see here in regards to the proportion of patients that we're seeing in those different categories, those patients with, at the bottom here with the late onset myasthenia and having some other autoimmune disease, and more commonly that was either a thyroid issue, lupus, and they also mentioned certain types of skin conditions as well, like psoriasis, that those patients were more likely to experience an exacerbation. And then again, we talk about late onset myasthenia even without autoimmune disease and so on there. So when we look at the Myasthenia Gravis Foundation of America classification, this comes into play clinically, and now is also often very important in regards to our documentation on our notes for us physicians. And of course, patients can go up or down on this scale depending on their disease course. When we talk about class 1, these are purely ocular symptoms. Then classes 2 through 4 talk about patients who also have generalized symptoms as well. And then these from 2 to 4, it's broken down between A and B as to whether or not we're talking about primarily limb affected, or in the B, mostly what we call either oropharyngeal, respiratory, or bulbar symptoms. And then at the 5 is when patients are in that crisis mode, when they're intubated and severely ill. So what things do we need to look out for in regards to a myasthenia gravis exacerbation? So in the vast majority of cases, there are identifiable causes. The most common are going to be infection, surgery, and then medications. This was another study done in 2019 that looked at various factors associated with myasthenia gravis exacerbations. When you look down here, if you can see there, the yellow bar and kind of the grayish bar, VPI and VNPI make up about 30%. These stands for vaccine preventable infections. These are things like the flu, and then vaccine non-preventable infections like cellulitis or urinary tract infections. So that makes up a good proportion of what can happen. And then the next category there, MAUC, stands for medications to avoid or use with caution in patients with MG. And again, that's making up about 20% in their study of patients who had an exacerbation. I also want to point out there the kind of light colored blue bar at the top, that social stressors are also an important factor when talking about myasthenia gravis exacerbation. Patients with myasthenia do not live in a vacuum. And so other things going on around you, other illnesses with family members, things going on with your children, with your work, are also can impact you having an exacerbation. And then for about still a quarter of patients, though, with the reason for the exacerbation is unknown. And so one of the things that's been brought up multiple times is the cautionary drugs to use in myasthenia gravis. If we look at this, the biggest thing here is the antibiotics. These are most of the medications that we are caution patients against, and make sure that they advise their primary care doctors and even doctors who they'll meet if they have an exacerbation in along with their care path to be careful of. The picture on the other side, I won't go through in detail, but outlines where we think those certain medications work along the neuromuscular junction and how they're impacting the effect of the neuromuscular junction, either blocking the calcium release for the acetylcholine, or working against the clustering of the acetylcholine receptors at the neuromuscular junction, et cetera. I do want to point out certain medications on here. One is magnesium. And I believe that, one of our panelists brought up before that the doctors want to give her high doses of magnesium. That is definitely something that we say to avoid. We see this sometimes in patients with preeclampsia for pregnancy, or sometimes even use this as acute management for migraine. But these are things that these high doses patients should not have. However, sometimes my patients say, well, can I have my multivitamin that has magnesium in it? That is fine. Typically, no problem in those magnesium doses you would see in supplements or in foods. Also want to mention here about corticosteroids. And so we'll talk about that a little bit later, but as we all are aware of, steroids are typically a part of myasthenia gravis treatment. However, we do need to be careful in regards to how we use them in patients. And then lastly, the last bullet point there is something called immune checkpoint inhibitors. So these are a newer class of medications for cancer treatment that some patients have, that we see that either they exacerbate or they even, patients on these even develop myasthenia gravis. But another point I also want to make in regards to the antibiotics is that if you have an infection and that is the only antibiotic in all the world that can treat that infection, it's really important to make sure that you get healthy and that infection is treated, but make sure to be in close contact with your neurologist in regards to any kind of management adjustments that may need to take place during that time. So we talk about different types of signs and symptoms that you may see with an exacerbation. So one is drooping eyelids, also called ptosis, and this can be unilateral or bilateral. Neck weakness, usually it is a head drop that patients have an issue with. Facial weakness, and what we can see here is that patients may notice they have decreased facial expressions, decreased ability to have a smile. They may notice jaw fatigue, especially when chewing harder or solid foods. And then impaired lip or eye closure. Some patients may mention that they notice that they're dribbling or drooling out of the side of their mouth, and that may indicate some face weakness. Patients may also mention blurry vision or double vision. And then we can also see limb weakness or fatigability. And this often is not, I have limb weakness or fatigability, but you notice that there's certain tasks that are more difficult, less exercise tolerance, less ability to walk or rise from a seated position or use the stairs, difficulty with raising the arms or keeping the arms raised above the head. Other things that can be seen are speech changes. Either patients can have slurred or nasal sounding speech. A lot of my patients call it their Daffy Duck speech. Difficulty with swallowing either liquids and or solids and difficulty managing secretions. Some patients may even feel as if they're something that they're swallowing is coming back up through their nose, and that is sometimes an indication of palatal weakness. And then lastly here, shortness of breath, and this can occur at rest or with activity. If you notice it when it was worse with lying flat, we call that orthopnea. And what we may also see, especially if the shortness of breath is more severe, is use of accessory muscles. So that's use of the muscles up here, kind of by your clavicle, as well as your rib muscles, in order to try to help with breathing. Now, as you can see, there's a variety of different symptoms that can be associated with a myasthenia gravis exacerbation, and not all of them have to be managed on an inpatient basis. And also, as brought up earlier through our distinguished panelists, is that you have other obligations, and so sometimes just going to the emergency room is not possible. So there is a possibility of outpatient management for an exacerbation. So minimal or mild symptoms, and these may include drooping eyelids, vision changes, or mild extremity weakness, can often be managed as an outpatient basis. Now, as we all know, that the myasthenia gravis symptoms are fluctuating. So you may have better vision in the morning and worse vision at night. And you may notice that your ptosis or your drooping eyelids is better in the morning and worse at night. But it's when these symptoms start to become more persistent that you definitely want, because the initial part may be that you're not on the ideal treatment plan yet. But when these become more persistent, this is where we're concerned about an exacerbation, and some type of intervention is recommended. So we contact your neurologist's office and schedule an appointment. The thing now is that oftentimes virtual appointments can be more easily scheduled than inpatient, if that's an option for your neurologist. Your neurologist is going to perform a history, ask about what things are new or different that are going on that may have resulted in this exacerbation. A physical exam should be performed. And then if there are any potential provoking factors, a new medication that was started, anything like that that we can adjust, then those things will be adjusted. And then the adjustment of your current treatment. Now, this will depend on what treatment that you're already on to determine what adjustments may need to be taken, what may need to take place, such as either increasing or the addition of a steroid, increasing how often you get a certain infusion, if that's possible. And then we want to also make sure in regards to treatment adjustments, however, that please make sure to contact your neurologist about any planned adjustments. So even if it's taking your pyridostigmine, the Mestinon, more often, you want to be careful with that, because patients can have what's called a cholinergic crisis by taking too much of their Mestinon, in which they would have excessive drooling, what we call flaccid paralysis, or extreme weakness. They can have breathing issues and almost look like it's a myasthenia gravis exacerbation or crisis, but it's really because they were trying to keep up with their MG symptoms by increasing the amount of Mestinon they were taking. And then during this time, you want to make sure that you maintain frequent contact with your neurologist about the current status of your symptoms, whether improved or whether not improved. And then, as mentioned earlier, there's a low threshold for going to the ER or hospital if there's any symptom worsening. So when you go to the hospital, you're going to start with going to the emergency room. And so this is going to be for moderate and severe exacerbations. So progressive difficulty with the swallowing or shortness of breath, and moderate or severe muscle weakness. If the shortness of breath is very severe, if the muscle weakness is very severe, then call EMS or immediately present to the nearest emergency room. I work in Houston, but not all of my patients are from Houston. Some are from hours away. And while all of my patients would like to come to where I am, sometimes that's not possible. You want to make sure you get stabilized first at the nearest ED, and then either transfers or discussion with the neurologist at that hospital can occur at a later point. But we want to make sure that you are safe first. When you go to the ER, the ER physician and staff will triage you just like they do for anything else, and ask about what symptoms you're experiencing. And so, of course, having worsening shortness of breath and swallow are very serious conditions, and please make sure to Again, advocate for yourself because some of these ER doctors may not be as familiar with myasthenia, and you may sit there looking like you're okay, but you're really not okay. And we all know that patients with myasthenia, unfortunately, can take a turn quickly. They're going to get a history and a physical exam from their perspective, and then do some labs and imaging. And this can usually includes an infectious workup, looking at different electrolytes, getting either a CAT scan or a chest or an X-ray of the chest to look for any signs of infection, maybe a urinary urinalysis to look for any signs of urinary tract infection. And then if possible, if available, we strongly recommend neurology and pulmonology consults. Unfortunately, not all hospitals, especially those in more rural areas, have these providers on staff at all times. And so if you go at night, these may not come into the morning, but definitely need to be part of the team. If there is a neurologist that's there, they'll come and see you in the emergency room and perform a bedside examination. This is going to be similar to the examination that your doctor should be performing in clinic as well. But they're going to look at what's called the prolonged upgaze, and they typically have you look up for a certain period of time and see if there's any fatigability or weakness in the eye muscles, whether or not you start having double vision or blurry vision, or whether the eyelids start to droop as you look up and we start to fatigue the eyes. We may perform certain types of exercises to see if there's any voice changes that occur. And sometimes we already know just by how you sound or after you've kind of said part of your history. Look at eye movements. Sometimes patients with myasthenia have difficulty just moving their eyes left or right or up or down. We call that ophthalmoplegia. And then we look again at facial strength or neck strength to see if there's any issues there. And then look at muscle strength and not only how strong you are, but also called fatigability. So oftentimes the neurologist will look at whether or not there's any issues with repetitive movement. So they may ask you to put your arms out and move your arms or move your fingers and see how long you can sustain before you get weak. And then a good bedside pulmonary function test is what's called the single breath count. I call it the poor man's functional vital capacity, because that's basically what it's looking at is how much air you're holding in your lungs. You want it to be about 20, which equals about 2 liters or so on the FVC or functional vital capacity when the patient's counting at a regular rate. And even though we do that bedside single breath count, formal pulmonary function testing is strongly recommended. And so this is looking at diaphragm function primarily, looking at what's either called some places a NIF or a negative inspiratory force, or a MIP, a maximum inspiratory pressure. And this, like I said, is measuring more so diaphragm function as opposed to actually the capacity of oxygen in the lungs, but we do get the FVC as well. And it's important to note here, and sometimes I've had, unfortunately, my patients have to educate providers that oxygen saturation is not a reliable measure of respiratory distress in patients with myasthenia gravis. This is typically what we call a hypercarbia or a more CO2 issue because the diaphragm isn't functioning as opposed to you getting oxygen in and maintaining your oxygen saturation. Usually oxygen saturation does not drop until patients are more severely affected. So this is not a reliable measure just because the O2 monitor says you're doing okay. If there is evidence of any type of infection, usually the ER docs will go ahead and start something. Again, it's important to educate those physicians on what antibiotics should be used with caution. You may get some IV fluids or correction of electrolyte abnormalities, as mentioned here again, you want to avoid those high doses of magnesium. And if there's swallowing issues, you want nothing by mouth until there's a formal evaluation in order to prevent any type of aspiration. So anything that you're swallowing going into the lungs and causing more issues. And this is just a brief checklist that I created that talks about certain things that I recommend when going to the emergency room. One, make sure to take an updated list of all your medications and treatments and your treating physicians. You want to keep a list of medications to avoid or use with caution in patients with myasthenia gravis. You definitely want to inform all the emergency room providers that you come in contact with about your diagnosis, what your current symptoms are, and who your neurologist is, any recent changes that may have occurred. We talked about getting formal pulmonary function testing. and formal swallowing evaluations. And then we're going to talk about in the subsequent slides what inpatient management will include, which typically is IVIG or plasma exchange. And then once stable, you want to inform your primary neurologist about what has occurred, and then try to schedule a follow-up with your primary neurologist as soon as possible after discharge. So when we talk about how is this managed on an inpatient basis, patients with myasthenia gravis who are having an exacerbation and of course definitely a crisis need to be admitted to an IMU or an intermediate care unit or the ICU, the intensive care unit. At this point, we're going to stop any contributing medications that we may have discovered, and this includes your mestinon. So don't be surprised if the doctors stop your pyridostigmine when you first go in here, and that's because sometimes if you have difficulty swallowing or managing your secretions, as many of you know, mestinon can increase your saliva, and if you're already having trouble swallowing, that can lead to more problems. You're going to get regular monitoring of your pulmonary function. However, this should occur at a rate that's regular but not too frequent in order to tire, and that's causing more fatigue or tiring the patient out. Typically recommend about every 6 hours or so. If necessary, we want to start non-evasive ventilation first. This is, for example, the use of a BiPAP machine, and this can prevent or delay intubation in about 50% of patients with a myasthenia gravis crisis. Intubation, however, may not be avoidable, and elective intubation may be discussed with the neurologist, that if we're seeing that there's continued difficulty with managing the secretions, if we're seeing that the pulmonary function testing has continued to trend in the wrong direction, then intubation may be discussed. And this is something just in order to allow your diaphragm and the other respiratory muscles to rest. So this is not necessarily anything that is critical, or meaning that this is some kind of end of life procedure, but this is something really in order to help for you to rest. And the other reason why patients need to be with IMU or ICU monitoring is for the cardiac monitoring that needs to occur as well. About 20% of patients with a myasthenia gravis crisis may have severe arrhythmias or abnormal heart rhythms that can cause serious complications. And there are many proposed treatment algorithms that are out there in regards to the management of myasthenia gravis. And I just briefly put this one up here because at the very bottom, it says never give up. And so I think that is definitely something that is so important, and something that both providers and the patients need to make sure that we're aware of, that we're never going to give up, whether we have to do plasma exchange over again or IVIG over again, or talk about other treatment options. We never want to give up, because myasthenia gravis, the vast majority of patients can make a full recovery. And so in getting to those different treatments, one that most people are familiar with is IVIG, or intravenous immunoglobulin. So this is an infusion of purified pooled preparation of the IgG antibody from the plasma of multiple donors. It works through several immunomodulatory mechanisms, decreasing complement and inflammation, and some mechanisms to which we're not even aware as to how it works. The typical dosing is going to be 2 grams of medication per kilogram of the patient's body weight, typically divided over 4 to 5 days. There are certain things that we have to be aware of in regards to using this medication. We do need to use it with caution in patients who have either some type of cardiac or vascular history, including patients who have a DVT or history of a deep venous thrombosis or blood clot, and in patients with kidney disease. Now, while this medication can still be used, we have to be careful, because while it is a lot of fluid, it's a lot of thick fluid. And so sometimes if the heart has more difficulty with pumping function, or patients have kidney disease and may have more difficulty filtering out all of that protein, that can cause an issue. And so modifications in dosing or scheduling may need to occur. And then so the most common types of side effects we see are headache, chills, and muscle aches. Sometimes patients have chest pain. We talked about the risk of clotting in regards to this medication, kidney injury, and there could be some other infusion-related reactions. The next most common is plasma exchange. It's also called plex or plasmapheresis or apheresis. Goes by several different names, but it works by directly removing the immune factors, such as certain autoantibodies, immune complexes, complement, and other inflammatory mediators. This is typically done by 5 sessions that are scheduled every other day. This may require central venous catheter placement, oftentimes in the neck or in the groin. And we have to use this in caution in patients who have an active ongoing infection, especially when that's like sepsis, blood infection, or if they're at high bleeding risk, because it does remove some of the coagulation factors or things that allow your blood to clot when you undergo this procedure. And some things to look for, of course, are sometimes there's catheter related events if you need that to be done. Sometimes it can cause little issues with blood pressure, and it can cause some issues with managing certain electrolytes. Now, for both IVIG and for plasma exchange, most patients tolerate them very well. Just in full disclosure, things to look out for and things that need to be discussed depending on patient-specific factors. And so we look at efficacy. So both IVIG and plasma exchange have similar effectiveness in treating myasthenia gravis exacerbation or crisis. Now, plasma exchange may be used first, may often result in a more rapid effect. And then if incomplete, IVIG may follow afterwards. Now, sometimes IVIG is maybe used first because of plasma exchange is not available at that particular location because of other patient-specific factors, or because there's certain types of tolerability or safety concerns. And so really what's used first is really dependent on a variety of different reasons. But I do want to show in this is that the study that was performed that looked at IVIG and plasma exchange and those patients who had days in the ICU and days on mechanical ventilation. So ICU is A and mechanical ventilation is B. So as we can see there that the white bar and the black bar are about the same. So the white bar is the one looking at plasma exchange and the black bar IVIG in regards to both of those as far as their efficacy. And the patients that didn't require either of those had less days either on ventilation or in the ICU, which likely, of course, makes sense. They probably were less severe than those other patients. And the ones that required both were more severe and required more days. Now, other management options. We talked about steroids before, and that this is something to kind of avoid or use with caution in patients with myasthenia gravis. And I'm assuming that for the patients here, there's probably many of you who have been on or are currently on some form of a steroid in regards to your management of myasthenia. But this is often part of the treatment plan for myasthenia gravis crisis. But the rapid or high dose administration can cause worsening. But this is less likely to occur if the patient is already on either IVIG or plasma exchange. What we're most concerned about is that high dose or rapid administration of the steroids causing issues with worsening of the breathing. So for our non-intubated patients, we don't want you to get intubated as we're trying to treat you. You don't want to make things worse. So typically start lower and then up titrate or increase the dose slowly over the next several days with some type of goal dose in mind, usually a higher dose depending on the severity. Now, for the patients who are already intubated, so we're not concerned about whether or not they're going to have some type of respiratory compromise, higher initial doses may be better tolerated. And so my last section here is about prevention. So unfortunately, no matter what you do, no matter what your doctor does, no matter how you try to avoid it, sometimes myasthenia gravis exacerbation cannot be avoided. But there are certain things that are important in regards to the care. So it is still Women's History Month for the next few days. So I thought I'd highlight Dr. Mary Walker, who is this lady here who was crucial in the use of pyridostigmine in management of patients with myasthenia gravis. She actually noticed that the antidote for QRA, which is a poison, allowed for patients to have a better functional better function and better strength. And so she assumed that it had something to do with the neuromuscular junction, but all the formal studies would come a little bit later. However, she did try a version of what we now call pyridostigmine on her patients, and this was back in 1934, and found that it was beneficial. Of course, the effects aren't lasting, they do wear off, but this was one of the major landmarks in regards to myasthenia gravis treatment, and even today, of course, remains a mainstay in regards to management. Now, it is symptomatic, and that it works at the neuromuscular junction in order to prevent the breakdown of acetylcholine, or that chemical that works on the muscle, so that more acetylcholine can be around that muscle and find as many functional receptors as possible. The dosing that this has is variable depending on the patients and their symptoms. However, tolerability can also be an issue. GI upset, usually nausea or diarrhea can occur, increased saliva, increased tearing and runny nose, muscle cramping and muscle twitching can occur. But this typically is a mainstay for a lot of patients. And I'm not going to go deep into this, but we all know that the best way to prevent an exacerbation is to be on effective treatment. And so there'll be a talk tomorrow in regards to what treatments are currently available and that we recommend. But these pictures are showing to where certain treatments are effective. So thymectomy on the thymoma and preventing the production of certain antibodies, rituximab preventing antibody reduction over here, and how plasma exchange works and so on. In the other picture as well, we see at the bottom that we see eculizumab, which is a complement inhibitor, and IVIG is also mentioned there, which also functions on complement, which is a protein that can come in and cause damage to the muscle membrane and cause worsening of symptoms. And there are several other medications there, some that are currently used for other conditions and some that are under study. And then more recently, we've had the development of the FcRn, or the fetal FcRn receptor antagonists. And these work by basically your body tries to recycle the immunoglobulins, including the bad IgG antibodies. Okay, their acetylcholine antibodies is what the study was done on, but any antibodies, and puts them back into circulation. The purpose of these FcRn antagonists is to block the ability for the body to recycle as many of those antibodies, and so that less are put back into the circulation. This follows a kind of similar mechanism to plasma exchange and trying to reduce those antibodies, but through an infusion. And then talking about certain lifestyle modifications that occur. So fatigue and tiredness are things that were brought up earlier. So when we're talking about fatigue here, this is not fatigability as in muscle weakness, but actual feeling tired, just feeling overall fatigued. And this is present in the vast majority of patients with myasthenia gravis. And as we can see here, there is a lot of interplay with fatigue in regards to being less active, in regards to depression, in regards to disease severity and quality of life, and other comorbidities. And so management of fatigue is also part of the treatment strategy and management strategy to discuss with your neurologist. And other therapies can include cognitive behavioral, weight reduction, and pain control. And in addition, exercise. And so this has been a little more of a controversial topic as to whether or not patients with myasthenia should exercise, given that their muscles fatigue with more activity. But it was a recent study found that most patients with myasthenia are able to tolerate some form of exercise. Aerobic exercises can be performed with more rest periods. I often recommend for my patients, if you're going for a walk, that's great, go for a walk, but make sure you take your phone or somebody knows, because if you get out there and your legs go weak, then somebody needs to come and get you back. But this, you have to kind of know where you are. And then balance and stretching exercises, so yoga, Pilates, things of that nature in order to help. And it's important to avoid high temperatures. So we're here in New Orleans, Louisiana, and it is already hot at the end of March, goodness gracious. And then it is hot in Houston too. And so maybe running in 90-degree Houston weather is not something that I recommend, or the hot yoga classes. But exercises can still be performed, and the type and length of exercises really depends on where you are at your point in your clinical and physical status. And then lastly, talking about diet. So this is something that has been less studied, but is more recently, there has been some information about how diet affects certain types of neurological conditions, specifically certain types of autoimmune neurological conditions. And there hasn't been that much scientific studies performed on this. Well, the data that we see now is that a low gluten diet, one that avoids processed sugars, and one that is more high in fruits and vegetables is beneficial. There was a study that showed that more plant-based diet is helpful. And a lot of these, it really is about reducing oftentimes the other comorbidities that patients may have, whether it's diabetes or being overweight, and being on these more healthy diets help that as well. And then lastly, there's a look at the gut microbiome. So that's the good bacteria that is in the gut, and how this is influencing several conditions. It's a big one now in Parkinson's disease, and then we're looking at it for other conditions as well, as to how this influences either the development or severity of myasthenia gravis. And oftentimes a probiotic is recommended, but the whole actual interplay here has not been fully elucidated. And some additional recommendations: make sure for the early and accurate diagnosis, you want to have close outpatient monitoring, especially early in the disease course. As we saw back on one of the first slides, patients are more likely to experience a crisis in the first 2 years, and that's when both you and your neurologist are learning about how myasthenia gravis affects you. And then doing patient and provider education. So what you guys are doing here to learn about what's available, what resources are available to you, learning how to be your own best advocate, and early identification of exacerbation symptoms. So as you learn your myasthenia, you're going to know, okay, I know things are heading in the wrong direction because my voice is now getting slurred, or my eyes are drooping a little earlier, and I know that's when things start to head in the wrong direction. Management of any comorbidities, and then vaccination. This is, again, a little bit of a controversial topic, but more often than not, we recommend vaccinations for those vaccine preventable infections, flu, COVID, etc. So just in conclusion, just in summary, so myasthenia gravis exacerbations are common, although most are minimal to mild and can oftentimes be managed on an outpatient basis. However, about 15% of patients with myasthenia will experience a crisis requiring respiratory support, typically within that first 2 years. You want to make sure that as a patient, you're prepared with your medication list, medications to avoid, name of your neurologist, and any information on any recent health changes. We want to make sure there's close monitoring of your pulmonary function. As we discussed, oxygen saturation is not a reliable measure of respiratory distress, and elective intubation may be discussed. But the vast majority of patients who experience exacerbation or crisis will make a full recovery. We see that older patients may be, or those with another autoimmune condition may be more at risk, and prevention includes establishing care with a neurologist or neuromuscular specialist early, management of comorbidities, vaccination, and education, and achieving effective long-term management. And then diet and a healthy diet and exercise are recommended. All right, these are my references. I want to thank you all so much for your attention. And I'll take any questions if there are some.
Okay, sorry, got it. Hi, Dr. Anderson. Thank you so much for such a wonderful presentation. I have a question or two regarding the cautionary drugs. You mentioned about the immune checkpoint inhibitors and how they can exacerbate MG as well as potentially cause MG. Are you familiar with any other, or is there any data about other drugs that have a drug-induced myasthenia gravis?
Those are the newest ones that I'm aware of that have come out that have more consistent data in regards to kind of this drug-induced myasthenia, and it's managed as myasthenia.
Okay, and MG causes me to frown a lot. You have any recommendations for an alternative to Botox?
Oh. Good, effective, long-term treatments, and other than that, I don't think.
Any other questions?
Will these PowerPoints be available like on a
Oh,
website?
I don't know.
At the foundation website?
That's above my pay grade. I don't know.
Yes, they will.
Okay.
That answered my first question. Second question is, as a caregiver, I arrive at the emergency room, patient can't talk. What do I do to keep them from separating her and me? Because I have the information they need. They're gonna haul her off into another room and say, no, you can't come in. And I know how to handle it, but has anybody else experienced that issue?
Absolutely, great question. And one, I think that came up a lot during the time of COVID, when they were separating patients both in the emergency room as well as when patients even got admitted to the floor. I think that one thing that I would give our patients is kind of, I have MG card. And so that's so that's available, a nonverbal clue. You're going to need some supplemental information as to what's going on. And I think just, speaking up, being an advocate and letting the doctor know that, it's necessary, that I have information that's going to allow you to treat my family member more effectively, more efficiently. So those are definitely different things that you can bring up.
Question about use of CBD oil to help with muscle
Mhm.
relaxation.
So in my practice, I see a lot of myasthenia, I also see a lot of neuropathy patients. And so that question about the CBD oil comes up a lot. Right now, I don't think there's been any formal studies to say that there's been any contraindication to using it, as far as I'm aware.
In the back.
Hi there. You mentioned BiPAP being used in the ICU or in the hospital setting. I've had a BiPAP at home for the last 14 years. And I never realized how much sleeping I wasn't getting that was making my MG worse. The BiPAP has been absolutely delightful.
Absolutely. Yeah, no, I agree. So in the management of acute exacerbation is definitely something we use in the hospital. And then as part of your ongoing treatment or as part of on discharge, the pulmonologist may say that this is still required for the patient to go home with. Oftentimes our patients with myasthenia have a pulmonologist that they also follow up with to help with titration of the BiPAP. So something still may be necessary.
Thank you for explaining IVIG so well. I've had several IVIG treatments, and I just wanted to know what your thoughts were on IVIG maintenance. Is that something that they're going to approve at some point?
If it was up to me, the answer is yes. It is all insurance. Anybody here from an insurance company? The issue typically is insurance authorization. And so IVIG maintenance is something that I do regularly in my practice, but there's protocols in place, and oftentimes there's certain different markers that have to be checked and so on and so forth. So more often than not, it's usually not your neurologist that's giving the pushback on that. It's usually the insurance company.
And we have time for one last question and/or statement.
Thank you. This is wonderful, and I'm sure the patients appreciate it as well. One of the questions that I had was regarding dysautonomia and comorbid POTS, as well as maybe other things that you see. Do you see small fiber neuropathy and other dysautonomic conditions, and how you kind of go about managing that along with this?
Absolutely. So it is not uncommon for patients to have dysautonomia associated with the myasthenia gravis. And that's why I talked about too, the cardiac arrhythmias that you can see sometimes with the myasthenia gravis crises, because there can be this issues with heart rate control, blood pressure control, etc. It's difficult. In isolation by itself, the management of POTS or the postural orthostatic tachycardia syndrome is hard. And typically there aren't really that great treatments for it. Oftentimes, I would say getting the MG under control often helps with getting any other associated symptoms under control as well.
Thank you, Dr. Anderson, very
All
much.
right, thank you, my pleasure.
Good afternoon, everyone. Michael Antonellis again. Good to see you all. A couple of housekeeping things first. I wanted to let you know that yesterday afternoon's welcome from Sam Masterson and the keynote are both up on our website, myasthenia.org. It is on the patient conference page, so you can view that replay. And the MGFA is making an even bigger commitment to try to post webinars and video communications much quicker than we have in the past. So you will see today's videos up tomorrow. So trying to get that 24-hour turnaround time. In addition, wanted to make sure that everyone knows that there are a few hundred folks in the community who are watching this patient conference via Zoom. They're actually watching it online, which is really cool. So I just thought if we could all acknowledge those folks and give them a big clap, round of applause or wave. We just wanted to make sure that they know that we know that they're watching. So the next session is really exciting for me. You may have seen our Alliance announcement last month. It is called Empowering the Patient. And I'm going to invite Jim Sliney, who is the Executive Director of Patient Outreach for Patients Rising. As Executive Director of Patient Content at Patients Rising, Jim works very closely with the people who have healthcare war stories to tell. As a Columbia University trained writing consultant, Jim has worked closely with writers of all levels of skill to help them find and refine their voices. Jim is a writer, editor, author, and medical assistant with over 20 years of experience in healthcare. He spent over 2 decades in clinical care and research at some of New York's biggest health institutions, doing hands-on nursing, education, and advocacy for rare disease patients. He has worked with several nonprofit patient support organizations, including, of course, the MGFA, doing outreach, advocacy, and creating educational content. He lives in New York City, and he is here to tell us more about Patients Rising. Now, I wanted to just let everyone know that based on our alliance with Patients Rising is providing several different capabilities, which is really, really exciting. The first focuses on a patient helpline, which we think is really great, and Jim will talk more about that. And also there are advocacy and educational services that they're providing. So let's bring Jim up to the podium. Jim.
Thanks, Mike. Thanks, audience. It's great to be here at the MGFA. I'd heard of myasthenia gravis many years ago when I used to operate the oh, is that better? All right. It sounded great back here. Yeah, I'm relatively new to myasthenia gravis. I had heard about it when I was running the neuroscience and behavior course back at Howard Hughes Medical Institute many years ago. And the only thing I knew of it is I saw the classic photo of, like the droopy eye and the droopy mouth. And now here I am talking to all of you, and I'm really excited to be learning so much from physicians and patients alike. So to talk about patient empowerment, the first thing I really need to let you know is that you're the only person who can really make yourself empowered, right? Empowerment is a self-actualization process where you find the tools that you need to be more successful as a patient. That's important because, of course, we live with a very complicated, sometimes a little backwards healthcare system. So we need to know how to navigate. You need to be a good driver of your own vehicle through healthcare. And I've always believed that that really begins with self-education. All right. Now, I'm speaking to the choir because people who are here or watching on Zoom are already people who've decided I'm going to engage with this patient support organization and learn as much as I can. So this may end up, apparently I'm too tall for the microphone. If I had $1 for every time. So thank you very much. So learning about your disease is incredibly important. That's why you're here. So this message, I guess, is for the people who aren't here and who may be watching this at some future time. Studying up on your disease, symptoms, signs, and treatments, and research opportunities that are available is really crucial. Because when you go into a conversation with your doctor, you need to be speaking the same language. Right? In most diseases, especially complex diseases like myasthenia gravis, it's really easy for the physician to be speaking over here and the patient over here, and they're not really coming together the way they need to. So understanding the terms and phrases that doctors use helps you communicate better with them. That's health literacy, essentially. At Patients Rising, giving people learning opportunities is one of the most important things we do. Because as we find out, we take what we learn, and that's how we decide what educational opportunities we're going to create. One, for instance, is when people have been somewhat frustrated and not feeling empowered. So we created a legislative advocacy course. It's like a 15-week course, about 12 lessons that teach you how to go to the Hill and talk to Congress about the changes that you feel need to be made in healthcare. It's been very successful. We graduated about 200 people so far. There's going to be a lot more to come. We're about to start our new class. But the whole reason it exists is, like I said, because there have been people like anyone in this room who wants to speak up but is nervous or doesn't know how. So for those who want to get involved in legislative advocacy, that's one offering that we have. But this isn't an ad for Patients Rising. This is about how you go from being passive in the delivery of your healthcare to being active. All right. One of the other very important things to do is to lean in to your patient support organizations like the MGFA. Again, you're all here, so you know this already. But out in the wild of healthcare, if there's an MG patient who's newly diagnosed, there's a lot of fear. Any new diagnosis is frightening. You don't know where to go. You don't know what to do. So leaning on people who've already been through that scary time and have learned a lot from it is really important. So leaning into the MGFA, organizations like, well, there's a good nonprofit for just about any disease state out there. So investigate those and trust that they're there in your best interests. When I first got started in patient advocacy, we counted on Facebook groups a lot. And you've probably all experienced this, that at some point or another, Facebook groups get a little toxic. Or a lot toxic. I've seen two nonprofits in the same disease space going at each other for blood, and it's not a pleasant experience because we're supposed to all be in this together. So be careful what you see on Facebook. Anybody can say anything about anything. So we always teach our audience to go searching for the most reliable information you can find. Whenever I'm looking up a disease, the first place I go is the National Library of Medicine. Okay. They have really good, up-to-date information on most diseases and treatments. Where if they ever fail me, I go right over to the Mayo Clinic site or Johns Hopkins. If it's a household name, it's good chance you can trust what they're showing you. All right. But of course, that's just your first foray into understanding your disease, because what you're seeing there may be very detailed, but it's also generic. What you need to do to take it to the next level is work with your patient support organization, like MGFA, because they then take that information and translate it into your lived experiences. Because it's what you're going through that defines the reality of any disease. Scientists and doctors can come up with all kinds of plans, tests for measuring things, but it's really your input, your feedback that makes all the difference. So to be an empowered patient means being bold enough to speak your truth when it's necessary. In the earlier years of my clinical, my time working in clinical trials, I found that most rare disease patients showed up and dutifully listened to everything that their doctors had to say. And there wasn't much of a two-way conversation at that time. That's unfortunate, because I would argue that the doctors have as much to learn from what you have to say as you have from what they have to say. You're an expert in your disease state, in your signs and symptoms. So you should always feel emboldened, empowered to speak up at any opportunity. As a matter of fact, one of the things that we're going to be doing later this year is we're going to be forming a storytellers guild, one where it's sort of like a speakers bureau, where we're teaching people two primary things. One, how to tell your story for your own therapeutic benefit, right? Your story is often trapped inside you. You need to get it out, all right? Sort of like sticking your finger down your throat. You need to get that stuff out of you. Sorry, are we far enough from lunch to do that? I'm sorry. But getting that out is really important. So I'm a big proponent, personally, of journaling, all right, to keep track of your own thoughts and experiences with your own disease. But at the same time, if you take that kind of storytelling and you bring it to your doctor's appointment or to your congressional representative, you're not going to get a lot of traction, because one version of your story is very raw and emotional. The other one is really meant to be a bit more strategic. How am I going to get the treatment that I need? This is what I need. How am I going to get someone to give it to me? That's strategic storytelling. So we'll be focusing on both types. And it'll be open to everyone. So you're all welcome to come and be a part of that. I'll let you know when it goes live a little later this year. We also believe that there are certain skills that every patient needs to have in order to have success. Now, the incredible speakers we've had so far have all touched on things like this, understanding how your insurance works, for instance. A very complicated process, of course, but the more you understand, the less likely you are to fall into the traps that insurance sets for you. And I don't mean to sound too cynical, but actually I take that back. I mean to sound cynical. You need to know the tricks that they're using so that you can step around them. And so we got some good talk on that earlier, but there's always more to learn. I've never found one place that kind of tells me everything I need to know. But that's part of research and learning again. It comes back to understanding the things you need to know in order to have a confident conversation with your doctor, because it's all about the doctor-patient relationship. Insurance is there oftentimes as an obstacle. Pharmacy benefit managers, you know, your CVS and Rite Aid, they'll give you lots of reasons why you should try this other drug first instead of the one your doctor wants. If you understand how these companies work, you can better make your arguments for not taking their step therapies towards the drug you actually need. And that's another part of empowerment. I think networking is also a very big part of empowerment. Again, that's happening right here, right? We're all meeting with each other. Some of us, most of us, I guess, for the first time, since this meeting has been virtual for a while. A lot of meetings have. It's good, by the way, to be back in the company of other human beings. Yeah, I'm not going to get over that or take that for granted anytime soon. But networking with your fellow patients and caregivers is where you're going to maybe save yourself some grief. Because if I hear a story from Joe from Rhode Island, maybe it's going to apply to something I'm about to go through or have been through. And together, the collective patient experience, the collective physician experience and caregiver experience should happen in a big pool that we can all reach into when we need to, okay? And I think the final thing I want to really talk about is this new strategic partnership we have with the MGFA, which is built around our patient helpline. The reason the patient helpline exists is because it's hard for people to ask for help. So we let people call us anonymously if they want, or email us so they don't have to interact with a person, or even just fill out a form if they want to be that detached from it, so they can tell us what their issues are. Then one of our navigators is going to get back to those individuals and have a little bit of a conversation, because when we find out that someone is saying, I'm having difficulty paying my rent, it doesn't take much of a conversation to suddenly find out, well, this means you're also skipping some of your medications because you can't afford them, that you're maybe missing medical visits because you can't afford to catch a cab, or you don't have a car, or you live out in the middle of nowhere. There are a lot of things that every one of you in this room has had to overcome somehow in your quest for wellness and respectable care. And so the helpline is there to field all of these issues and find solutions for them. The easiest example to give you is transportation, because it seems to be the biggest issue facing patients across the entire country. I live in New York City. I can hop on a bus or a train. I don't particularly want to, but I could. So I can get anywhere I need to get. But I realize that's a great privilege. Not a lot of people have that. So what do you do when you need to get to urgent care today or the ER now, but you don't want to mortgage your house to pay for an ambulance? There are lots of opportunities for federally licensed transportation services. They're kind of all around us all the time, but we don't know about them. So one of the things that we do at the Patient Helpline is we work with the Community Transportation Association of America to keep a database of where all of these transportation services are. So if you call us and say, I need to get to my urology appointment this afternoon, well, first we'll say, please don't call us the same day you need to get a ride somewhere, because we're not actually a transportation service ourselves. I'm not going to hop in the car and come pick you up. But I can tell you who will hop in the car and come pick you up. And we'll give, based on somebody's zip code, local transportation options for non-emergency medical transportation. That's a very common example, but certainly we have people coming to us as well who are caregivers who need respite. They need a break. Most caregivers, I think the stat is that 70% of people who are providing intense caregiving services are also working full-time jobs. That's a problem. That's a big problem. And so if someone has the foresight to give us a call, we can connect them with services that can provide respite care, someone who can come in just for the day. So you can take the day off and go get your hair cut or whatever, you take the car to the shop, whatever. We find also when someone enters into hospice that there's a lot of uncertainty. No one's sure what to do next. So we build some information around what you can do in a situation like that so that people don't feel lost and alone. And again, we do that so that patients can learn how to fish. And we don't want to give people fish. We want to teach people how to fish so that you can take better care of yourselves and not experience the kind of stress and grief that patients often do when they hit an obstacle they don't know how to overcome. I mean, it happens to me too. We're all patients, by the way, whether somebody has an MD, a PhD, or is a medical assistant like myself. We're all patients at one point or another. And so we all have similar obstacles that we have to overcome. So if we share our experiences together, we may be able to avoid some of those mishaps. And that's really what empowerment is about. Being able to take care of yourself, being able to speak confidently to those who have the ability to help you, your doctor, your insurance company, interacting with the hospital where you may be inpatient someday, and knowing how to have those conversations gives you the ability to be more successful as a patient. Instead of talking this whole time, I really want to make this more of a conversation. So I'm wondering if anybody out here has a particular issue, like an obstacle that they've encountered in their attempt to get care that you just don't know how to get around. It could be anything at all. Let's workshop some stuff together, okay? For instance, anybody here have transportation to your doctor issues, or you have a loved one who you think needs to be involuntarily incarcerated in the hospital because they have mental health issues or substance abuse issues. These are the kinds of things that people are facing around the country every day. And we want to be able to help with that. Yes. We're going to get Mike a lot of exercise today.
Yeah. I definitely need it.
So Jim, not a question as much as a comment. I gave your website a plug during my insurance talk.
Thank you.
Phenomenal website for resources. I have an electronic scooter that I use for family outings for anything that's longer than like walking around this building. but I can't go out with it myself because it's a portable one. I can't undo it, put it in my car. So for me, getting a lift for my car was cost prohibitive. And I actually found something on Patient Rising where there's a grant to get a lift for my scooter, for my car, that I can now fill out if I choose to. So more of a comment on, there is so much information on that site. So truly, I think any issue that we're dealing with, and thank you for saying, putting somebody in the hospital with, thank you. I think friends, family, anything you're dealing with, your site's phenomenal. I just can't give you enough kudos for it.
Thank you very much. But yeah, if we have a good website, it's really because we just listen to what people have to say. And when enough people say, I have this problem over here, we go and we research it and curate resources from the best places we can find. We'll even do projects with hospitals or sponsor companies to learn more if there's an absence in that space in knowledge. So you come to us and you're basically telling us what we should be doing with our time. So thank you. Question in the back.
This question's not for me, but we have a member of our support group that does not drive, and San Antonio has a bus system called Via. And if you're disabled, you can call them, but you never know when they're going to show up. And I have never heard of this National Transportation Association. Is that something that can help her? In fact, she even needs rides to our support group meetings and back.
Okay. Yes, the Community Transportation Association of America, the CTAA. Yeah, they maintain this database. Anybody can get access to it. It's not behind a paywall or password or anything. If you don't want to reach out to them directly, you can always reach out to us and we can do a little bit of legwork for you. We're happy to do it. But you're right when you say that a lot of municipal services like the one in San Antonio or Accessoride in New York City, you're really kind of throwing the dice about how long you're going to wait to get picked up, So a simple doctor's appointment oftentimes turns into an all-day affair because you may be waiting 2 or 3 hours for your ride to show up. Now, I don't think we have a really good solution for that, but we can tell you where to file complaints. We can figure that out. Yeah, we have some expert Googlers on our staff. So, and as far as authenticity is concerned, I like to let everybody know that the navigators on our helpline are themselves chronic illness patients who have been through the ringer. These are people who were on Social Security disability at some point, were able to come off and work full time with Patients Rising, but so they've seen a lot of the problems that are out there. So they're the real deal. If you call and you speak to them, you're talking to somebody who knows. That used to be me, but then we got better than that. So yeah, as a matter of fact, the helpline started back in November of 2019. And we had a great idea, which was we want to teach people how to navigate step therapy or copay accumulators, other policy issues that seem to be talked about a lot by patient advocacy organizations. But within a handful of months, it was March of 2020, and then everything changed. And suddenly we weren't getting calls about step therapy. We were getting calls about, where do I find food? Like I'm out of food, or I can't pay my rent. What do I do? So the helpline changed from what we thought it was supposed to be, and it became the thing that the people needed. And I was very happy about that. It's one of the pitfalls that we experience in the nonprofit patient support space. We think we know, but sometimes we're right. Most of the time we miss the mark if we're not listening. So we've become really good at listening. So any of you can grab a card from off the Patients Rising table over there, either my business card or the patient helpline card. and test me, reach out, anything you want. We want to talk to you about what's going on in your life. Yeah.
Just had a question. I did grab your card and I planned on reaching out. I've worked in my job for 20 years and coming to the end of my career and never really experienced any problems with my work. They've always been accommodating. But as I'm coming to the end, suddenly things have changed and they are no longer so accommodating. And I'm now just wanting to know if you had any sort of resources on any legal aid or any sort of advice on where to turn for anyone struggling with that.
Yeah, I have some tips for you. First of all, most sizable employers have a disability office or a disability officer within the human resources department. Start with a conversation with that individual. All right. So if you feel like the accommodations that you had before are going away, even though your need for those accommodations has not gone away, then the disability officer needs to know about that. Because then it becomes part of the record. It's important that these things get written down by somebody in authority, right? But there are other ways that you can take action. One of the things I recommend is using the Triage Cancer website. Triage Cancer, well, they triage cancer issues, but they're really all about services that are useful to any chronic disease state. So they talk a lot about the disability rights of students and workers, as well as the financial supports that you can find as a chronic illness patient. It began mostly about cancer, but quickly ballooned out because more people had questions than just cancer patients. So Triage Cancer is a strong partner of ours, much like the MGFA is. So I recommend turning to them. You can find some excellent resources there. But start with the disability officer at your employer. Okay.
We do have time for one or two additional questions, if there's any.
Zack attack.
So this is a real personal question, but I live in a rural area and I cannot get services. Like I live too far from a bus stop to qualify for my county's transit system, for their paratransit system. And most days I can drive myself, but some days I really can't. And what am I supposed to do? Do you offer help in rural areas?
That's a really serious conundrum, right? We don't have a service in a rural area, but we're very good at finding the ones that do exist. There's actually, I don't know if they're still in business, but there was a site called Rent a Friend where you can actually rent somebody to drive you places or help you with groceries and stuff. Now, there's TaskRabbits and things like that that can help. Not ideal, but it's better than nothing. And I know that a lot of, like my mom, she lives in a very remote part of upstate New York. And my constant fear is that something's going to happen to her and she's going to need emergency services and it's going to take an hour for anybody to get to her, you know, and that's a really big issue. So I think one of the things that we take that issue and turn it into advocacy is we advocate for broadband internet access and telehealth access so that if someone's in a pickle, they can at least reach a provider, even if they can't reach them physically. Since most, well, not most, but there's quite a bit that can be done over the phone or on a video examination from a doctor. But if you'd like, drop me your zip code and I'll do some research for you. Okay. Thanks, Zach.
Anyone else? Great. Jim, thank you so much. We really appreciate it.
You're welcome. I have to leave you with a joke. I'm sorry. This is tradition. Okay. I got in really late last night because my I was telling people my flight was delayed, but that's not true. I went to a new restaurant in New York City called Karma, and it was very difficult to order there because they don't have a menu. You just get what you deserve.
Just to let you know, everyone, the Maya meeting will be upstairs in the Bourbon Room at 3:30. It'll start at 3:30. And the Little Things Make a Big Difference session will be down here, also starting at 3:30. Thank you so much.
Hi, if everyone can make your way to your seats, you are not going to want to miss this next session. Hello, my name is Laura Chandler. I am an MG patient since 2019, and I am thrilled to be the newest member of the MGFA staff, coming on board just a couple of months ago as the operations manager. And we are beyond excited to welcome you to join us today for Little Things Make a Big Difference, created by Alexion Pharmaceuticals, Inc. Featuring MG advocates Seth Castro, give a little wave or a vogue maybe, Seth. Amy Zahner and Liz Plowman. Moderator Megan Miller and Alexion Patient Education Manager will kick off the event. And moderator Jennifer Yates, a professional stylist, will be driving the conversation. Our featured speakers will share the ways that they have become self-empowered and the ways that they are more than MG.
There's so much silence. Can we get a little applause for these wonderful guys? All right, sorry, I just had to break the ice, everybody. Laura, thank you. And just a little heads up for any of you that are in the market for anything Kentucky, she's your girl. All things passionate, figure it out from there. But as Laura had stated, my name is Megan Miller and I'm a patient education manager with Alexion. And on behalf of Alexion and AstraZeneca and the More Than MG campaign, we wanted to thank all of you guys for, being here with us today. And then I'd also like to, or we would like to extend our gratitude to the MGFA. You guys have done an incredible job, delivering such a memorable, gathering. And I also want to thank you for allowing us the opportunity to experience your guys' passion and commitment firsthand and learn more about what makes you more than MG. Today we're honored to have the opportunity to speak about an important topic, which is all of you. It's very obvious in the past few days that we have all been here that you guys are committed and passionate about empowering each other and doing whatever you can to uplift your community. Despite of what challenges you face on the daily basis, it's sometimes hard for you guys to prioritize what's most important, which is yourself. So today we have the opportunity to hear from this beautiful panel of patients and advocates. I'm happy to present to you guys, as Laura had stated, we have Seth Castro, Amy Zahner, and Liz Plowman, 3 incredible advocates living with MG, and then Jen Yates, she's gonna direct this rodeo, and she is a stylist and an amazing artist herself. So together they'll be discussing how little things make a big difference, and provide you with some tips, concepts, some resources that you might find beneficial to implement into your day-to-day routine. First, some housekeeping. There will be some Q&A at the end, so hold your comments and questions till the end. And also, because this is an industry-sponsored educational event, we ask that you refrain from asking questions pertaining to treatment and brand, and please bring those questions to your healthcare team. And lastly, Myasthenia Gravis is different for everybody, hence the snowflake. So some of the experiences you hear today might be different than your own. So again, just emphasizing, please take those questions back to your healthcare team. So without further ado, I will introduce to you guys Jen Yates.
Thank you so much, Megan. I'm Jennifer Yates. I'm a licensed makeup artist, hairstylist, and esthetician. I've been involved in the More Than MG campaign for about a year now, and it has been extremely dear to my heart, getting to connect with these beautiful people. And it's really an honor to spend some time with you all and to chat with these incredible advocates. Seth, why don't you say hello and share a little bit about yourself? And then we'll go down the line to Amy and then Liz.
Sure. Hi, everyone. My name is Seferino Castro. I go by Seth. Originally from Brownsville, Texas, but I'm currently residing in San Antonio, Texas. First time in NOLA, so pretty excited. It's been 16 years since I was diagnosed with ocular myasthenia gravis. And what do I do for a living? I'm a call center manager. Yes, guys, I love the stress. So definitely, I'm a strong advocate for MG, specifically in my day-to-day life and also in social media. And thanks to social media is how I got the opportunity to work with the More Than MG campaign and just obviously just enjoy advocating for MG because as you know, as everybody says, we are the snowflake disease. So definitely like to share that we're all a little different. Amy?
Hello, everybody. I am Amy Zahner. I am the CEO, founder of LLC, a new startup, and it is called Everybody Empowered, emphasis on the body and empowerment, empowering everybody in everybody, everywhere. I am a rare disease advocate and I specialize in resiliency and overcoming adversity. And in the MG world, we know we need that so much. I am working to provide advocacy, patient advocacy, education, and coaching for my MG community, as well as other folks with rare diseases, chronic illness, and disabilities. Liz.
Thank you. My name is Liz Plowman. I am also hailing from the great state of Texas, coming from Houston. I am a Navy veteran, medically retired from the Navy. I'm a physical therapist. Whether you have a love-hate relationship with my profession, that's a topic for another time. I absolutely love what I do. I've had myasthenia gravis for just over 5 years now. I have generalized seronegative myasthenia gravis. It has, definitely changed my outlook on a lot of things, including my practice of physical therapy. I used to be very staunch orthopedics. If it was a neurologic condition, I wasn't touching it with a 10-foot pole, and the universe has a really good sense of humor. So I embraced that, and now I absolutely love my neurologic population because I am one of them. I'm advocating for MG is very, very important to me, both as a patient and as a healthcare provider, and getting education out to patients and to healthcare providers on how to work with this very unique disease is very near and dear to my heart. It's an honor to be here.
Thank you all again so much for being here. We appreciate your participation in the More Than MG campaign and in this discussion. During this session, we'll be covering the following topics: the physical and emotional impact of living with MG, which we know is unique for each and every person, the value and importance of prioritizing self-care, and taking charge of your physical and mental health. As you know, all people living with MG are different, whereas while our speakers will be sharing their personal experience today, it is important to talk to your doctor and healthcare providers for medical advice. So let's start with the physical and emotional impact of MG. And just to let everyone know, I'm going to ask the audience to participate with us a little bit today, if you're comfortable with that. By a raise of hands, how many of you feel like MG sometimes makes it difficult for you to get ready in the morning, whether physically, emotionally, or both? Wow. I know that our advocates up here can share some of the ways MG has impacted them in this way as well. Seth, when we met last year in San Antonio, you shared some of your experience as to how MG affected your appearance and how that made you feel. Can you share a little bit more about that?
Of course. So when I was first diagnosed, guys, I asked that typical question: why me, right? What's going on with me? So as it was starting to kind of start happening, I started kind of studying a little bit more information about MG. I was actually doing medicine. So as you guys heard in the morning panel, some of the doctors actually draw and explain, the whole neurotransmitters and stuff. That made sense to me at that time. But as I was learning and growing with my my actual neurologist on what was going on with me, it started just kind of focusing on my eyes. So he changed the diagnostic to an ocular myasthenia gravis. And that's where the fun began. I had to get a patch, and we both agreed that the patch was going to be the best way to go. And I kind of called it like Goldilocks and the Three Bears. Who's familiar with that story? So I had one that was like, is this the right one? Too big, too small, too pointy? Because I do wear glasses. But then I had the right one. So I found the right one. And that's pretty much how it kind of got me into understanding and kind of going with my way with the whole eye patch scenario. But on the flip side of that, guys, unfortunately, there was a lot of negative comments where I actually grew up from. There was a lot of, look at the pirate, Halloween's over, or, you know, what did pirates make? R, right? So I would have that. Children was okay, but adulthood, they were a little harsh. So it made me kind of wonder, because right now I'm 38, 16 years ago, I was getting ready to be an adult per se. And it was kind of sad to hear that my future adult friends were actually the ones causing the harm. But that's a little bit of the harsh stuff.
Wow, I can see that must be frustrating. Imagine repeatedly getting comments from strangers who are unaware of Myasthenia gravis, that it would be very frustrating at a certain point. How did those experiences affect your self-confidence and mental health, particularly in the very beginning?
So it was a little depressing. So, you know, depression did stroke a little bit. I had to understand what was going on with me, as well as understand the knowledge, but the depression did hinder my knowledge of MG for a while. But one thing that I can tell all of you guys is just, I never gave up. Luckily, I had a very strong support system from my family, my friends, and my husband, who's currently out there, by the way. But they all helped me understand and kind of grow and accept myself. You know, I was in a transitioning phase. So I was trying to understand what MG was really doing to me, and was the patch going to be the right thing for me? But eventually everything just got very well informed. And of course, the support system was great. And that's what made me actually strive to keep going and never give up.
That's amazing. That's amazing that you had such a great support system that helped you through the more challenging times of your MG diagnosis and face that outside negativity, especially while handling a significant change. I'm sure there are many others in the MG community who are dealing with ocular symptoms and possibly trying to figure out if a patch might be right for them. What would your advice to those people be if they're considering that?
Don't be afraid. And funny, we talked about that this morning. You guys were hearing that conversation, but don't be afraid of wearing an eye patch, guys. As I joked about it, it does take time to find the right one to actually play with it. So if I could give you some advice, is go to your local pharmacy, get yourself a patch. There's also some in Amazon, I think, but I say start close, right? Try it on. Don't be afraid. Walk around your house, walk around your park, you know, wear it, kind of get used to it. And don't be afraid to bump into things. That's going to happen. Okay. But our body's going to go ahead and get used to it. Your peripheral vision's going to grow. And it worked for me. I'm not afraid to try new things. So I strongly suggest that would be the advice. Get that patch and don't be afraid to try it if you happen to have the ocular. It actually also helped me personally with droopy eyelids. I really hated the droopy eyelids, y'all. But one of the things that I can tell you is that because of the force, it started kind of relaxing my muscles since I'm not straining them. But that would be my advice for all of you guys. Try the patch, see if it works for you.
That's really great advice, Doug. And I think it looks amazing also. Thank you for sharing all of that. Amy, how about you? How did MG originally affect you physically and emotionally from an everyday perspective?
Sure thing. So I have LRP4 positive MG. I am double seronegative, or everything else is negative for me when it comes to those antibodies. And I have generalized myasthenia gravis. And I also had refractory MG a couple of years ago, just like 2 years ago. Symptoms from MG, despite my treatments, weren't doing enough. And I was suffering from a lot of issues with dysphagia and having choking episodes. And it was not looking that great. I had to really contemplate how I was going to proceed because, you know, I was facing the challenge that this disease may bring me to an end. And that's, you know, like the most devastating part, as we know, in thinking of our fellow snowflakes and not wanting to lose any of us in our community, because we really are such a strong MG family, and especially through MGFA. Like MGFA has been there from the beginning for me of my journey with MG, which started back in 2012, where I was first given a little boop, here's a diagnosis for you. Actually, no, I'm going to take that back. I don't think you have it, because there wasn't an LRP4 test available yet. And we didn't get to find out until 7 years later, when my diagnosis got confirmed after 4 single fiber EMGs and multiple testing. And so my diagnosis got confirmed, and then began the journey to figure out treatment. And moving fast forward, we get into my everyday life, right, with MG. And I live in New York. I forgot to mention that earlier. So I'm a New York City kind of woman. And if any, how many of you have ever been to New York? Just out of curiosity. Yes, ma'ams and sirs, hello. So you guys know what I'm talking about. We move at warp speed in New York. But what speed does an MGer walk at or move? Thank you, snails. Snails, what's our other mascot? Exactly. Okay, now, so here's sloth on the one hand, which is the reality for me with MG, right? On most days, that's my average. And then on the other side, we have the version of myself that was before MG, right? And that one was maybe, I don't know, fast like a tiger, or like put all kinds of fun animals together. And that was probably be something quirky, because we know that I'm a little different and eccentric, right, with my looks. Now, in thinking about approaching MG, it's such a drastic change, right? That shift from who we were before the diagnosis, and then the aftermath of like, what does this mean for me? How am I going to move forward? How am I going to get ready every day? How many of you guys, I'm just curious, how many of you raise a hand if you have any challenges with getting ready in the morning? Getting dressed, brushing hair, brushing teeth, putting on shoes is like super fun. It's like, oh, I got to lift my leg with my hand, pull it up. It's such effort, like literal physical effort. And something that I've had to do is like modify all the time, right? I feel like MG has brought me to this world of adaptation and spontaneity, right? I like to be that New Yorker, and like I'm organized, I'm in control, and we're always on time. There's always time. Slothland, we can't do time. We just can't. It's too much. And so I have had to modify how I do things, kind of come to peace with, you need to slow down and be realistic, because there is no rushing for me personally when MG is really active. I've got to keep it moving. So there's different ways, and I'll get into that in a little bit, of how I've learned to adapt, and also in the ways that MG affects me. One of the ways that Steph really touched on, and clearly with the eye patch, it becomes more visible that we're like, something is up that he has an eye patch, for anybody that doesn't know him and doesn't know about MG. For me, I get the lovely effect of MG that it affects my whole face on a regular basis in varying ways. And I am, as you could probably have a clue, kind of a girly girl. I like makeup, I like hair, I like things. I like putting my best face forward. But with MG, I don't know what face I'm going to show up with in the morning, or an hour later, or 10 hours later. And so, you know, looking in the morning, looking at myself in the mirror in the morning, I don't know what I'm doing with myself yet. Is it going to be a barefaced day where I go in with purge and I like face the world? Or do I want to use makeup to maybe like change things? And something that I've learned, which for anybody that wears makeup, and there's ways to apply this for men too, of like with the makeup world, using ways of hiding, concealing, or amplifying different things, and like thinking of it like painting, right? So starting out in the morning, I'm a Picasso painting. Like I've got an eyebrow here, and Liz, can you hold my other eyebrow? And you can droop down with my eye, put it down to the floor. Actually, if someone over on this side could take the eyelid and just like pull it all the way, actually all the way in the back. That feels, right, like how my face looks sometimes. It's so drastic at times that even my neurologist, who I've worked with for years, a top neurologist in her field, or in her specialization area. And even with her, she hadn't seen a true MG exacerbation or flare with me. And so when my droopy face, droops, it can get a little crazy. So I look like somebody that has a stroke, pretty much. I will have my whole side of my face like pulled down, or like cheeks sagging, eyes sagging. Like, where are you going? I feel like a character out of a show and I'm melting. That's kind of how I feel, that my face is like running away. So anyhow, we'll get into it. Let me give it back to you, Jennifer.
Well, that's all really great advice. It also sounds like it could be kind of draining both physically and emotionally. What advice would you have to give to someone who's having a difficult time with the emotional impact of MG, or someone who's having a tough time accepting the physical issues that can be caused by MG?
It's a great question. So as you can imagine, having had refractory MG, and in that challenge of like wanting to put my best face forward, right? We face the world with our face. Like, if we're going to meet anybody new, what are they looking at? Our face. And so like, if that's the point of reference, how am I presenting to the world? And right, our face, we're very self-conscious. I think, I don't know, is anybody else self-conscious about how their face looks? Raise a hand. Okay, thank you. So I'm not alone. I appreciate that. So, the impact that the looks, my appearance has on me, I feel is tied directly with my self-esteem. I don't want it to be that way. And it's not in a superficial way, but just reality, right? Like, this is how I present to the world. So I've learned that I need to address things a little differently. And I want to jump back into the emotional component of it, because in truth, having MG is like feeling a loss. For me, it was going through stages of grief and going through what I started to mention earlier, where you get that diagnosis and your life has just changed forevermore. And it's sudden, even if it was like gradual, like you knew something's up and then you finally get that diagnosis, or abruptly you get that diagnosis. But that moment that you hear, I have myasthenia gravis, or, that you're thinking, I have myasthenia gravis, your doctor tells you, the world changes. It's no longer going to be what it was before. It's something new, and it's unexpected, and it's a bit scary. It's uncertain. And with MG itself, it's like there's so much fluctuation, right? The unpredictability, the spontaneity that it requires, us not being able to follow through with commitments that we want to make, right? Or family engagements, or our relationships, or for single folks, for dating. That's a whole other topic. So it makes life super challenging. And, it hurts emotionally to not be able to do things the way that you did before, right? You have to think things over so strongly, even just to do transportation. It's not just like, oh, I'm going to hop on the subway and I'm going to meet you there. No, I need special transportation to get there. I have to use the wheelchair in the airport. I've learned. Otherwise, it's going to mean me putting myself into the hospital, because there's no way I could drag my heavy luggage. It's not happening. I have turned to different ways of helping myself to feel empowered. And so in doing that, how do you do that? Well, one thing I do is simple. I look in the mirror every day, and from childhood, years of bullying, I had to really overcome a lot to be able to look in that mirror and see my reflection. And I would tell myself, looking in that mirror, that I'm loved. I'm worthy of love. I feel like sometimes we get lost in the mix of the devastation of this diagnosis and what it means for us, and in all the ways, all the intersectional ways that it encompasses our lives. And so I have to look at myself with the facial droop and all the Picasso, and I'd rather be symmetrical and, organized and linear, and I can't be. And I've had to learn to find that self-acceptance. So I tell myself in the mirror, I look in the mirror, hey, I love you. You're not so bad. You're okay.
Thank you, Liz.
Thank you so much, Amy. You have such a beautiful outlook on things. It's great to hear how little changes can make a big difference for you. Liz, as a physical therapist and someone living with MG, what do you think are the most common challenges people living with MG experience when it comes to performing everyday tasks or going through everyday routines?
Thank you, Jen. I'm going to piggyback on, we planned this, we segued. It was, so a lot of the kind of daily tasks, things that we take for granted, just, how am I going to brush my teeth? How am I going to put my hair up? I was before MG, I was in the Navy, and I was, 15 minutes. I mean, we are early risers, and 15 minutes, I'm out of bed. I've brushed my teeth. I've washed my face. I've thrown on a little makeup, hair in a bun, uniform on, boom, out the door. 15 minutes. Post MG. Oh no. Oh no. How before or how after?
Exactly.
And so, so now as a PT, and I also want to kind of throw a little caveat out here. I'm speaking from my own personal experience as a PT, but I will also share with you that I do have the wonderful honor of working with a lot of folks in the MG community in my capacity as a healthcare provider, which has been an absolute amazing honor for me to do that. And so, so I've kind of learned to adjust my own activities while teaching other people. And that's actually probably one of the best ways to learn, because I'll be honest, as a PT, I can tell you I'm a horrible patient, absolutely horrible. But the biggest things is I had to take those everyday activities that I took for granted and rethink how to do them. So putting my physical therapy brain on, right? We never say you can't do something. We just say, okay, we're just going to change how you do it to make it doable. So, the next thing I knew, I was, for brushing my teeth, right? I chunked out my Walgreens toothbrush, drugstore toothbrush. And, I had the nice electric toothbrush, and I had my elbow on the counter, and I'm brushing my teeth, and it got the job done, but it didn't fatigue me out as much. And so that was really the thing, is going through those activities that I had taken for granted and figuring out how to do them in such a manner that did not fatigue me out, could still get it done and not be wiped out just trying to go through my morning routine. And so that was the biggest thing. But then also just, making sure I was showing myself some grace and being kind to myself and not putting pressure on myself to be out the door in 15 minutes because it wasn't going to happen. And that being okay with that and being okay with making those modifications and doing what I needed to do to take care of myself, so that I could enjoy my family, enjoy my at the time daughter, and now there's two of them. They've multiplied. They've stopped multiplying. But yes, so showing myself a little bit of grace.
Wow, that's great. Those are all great points that you mentioned, and it's also a great transition into our next topic, which is the importance of prioritizing self-care. The importance of prioritizing self-care is it's about taking care of your physical health and mental well-being through a variety of habits or routines. Before we get started, could I see a show of hands of people from the audience who like to practice self-care? And how many of you wish it felt a little easier to make time for self-care? Liz, in your opinion, why is it so important to prioritize self-care?
So I imagine a lot of us flew in here to come to this conference today. And so if you happened to listen to that security briefing or safety briefing, excuse me, on the airplane, if you listened, I believe they told you to put your own oxygen mask on first before helping other people. And that is kind of my theory about self-care. We cannot take care of others. We cannot go about the activities in our daily life with any real meaning if we have not taken care of ourselves first. And I think that's probably the hardest lesson for most of us to learn, especially those of us who happen to be in any of the healing or the service professions. We want to take care of everybody else. That's what we do. But just to know that we can't do that if we don't take care of ourselves. And then with this particular disorder, it's rest is, so before pre-MG, I was very much of the mindset, I go, go, go. I give 100%, 110% all the time, because that's possible. And sleep is for the weak. Right? I'll just keep pushing, give me some more coffee, I'm good, right? Keep going. And that does not work. Well, that shouldn't work anyway, but it certainly does not work in the post-MG world. And I learned really quick that rest is treatment. So I have, there's various medications and things that I take as part of my treatment regimen. I have certain, you know, I'm a PT, and so I do PT in theory. But rest is part of the treatment regimen, and framing it that way, that is how we take care of ourselves. And that is how we are able to have meaning in our day and meaning in our lives, and be able to have enough energy, or enough spoons, I think is the going term, left to do those activities that are meaningful. And I remember having a conversation with one of my primary care docs, and this was when I was asking for I was having him sign the paperwork to get me a placard for my car so I could use closer parking. And I remember saying to him, I said, I won't use it all the time. I'll just use it on a bad day. And at the time, my daughter was about a year old. And he was actually sitting with me in my living room. And he looked at me and he said, Liz, he said, would you rather spend your energy walking across a parking lot or playing with your daughter? I said, okay, good point. I'll use it. Thank you. So self-care, taking care of ourselves first has to be a priority, so that we can take care of those around us, and enjoy our lives and enjoy those around us.
Thank you so much for sharing that, Liz. What ways have you found to help manage arm fatigue that myasthenia gravis may cause?
So as I said, well, I like to think I'm a good PT. I'm a little biased there. So I mean, when I started having the symptoms of this disorder, I treated myself as I would treat a patient. And just again, caveat here, the advice or the information I'm giving, I have to protect my license. So I'm not giving any medical advice here. I'm just sharing my own experiences and the things that I've observed in my own patients and clients. So if you have any specific questions, please make sure that this is not medical advice and that you're discussing it with your healthcare team. I treated it. I said, okay, look, I'm having trouble with these activities. I'm having trouble washing my hair. I'm having trouble brushing my teeth. I'm having trouble sitting at a computer desk and keeping my arms up. So I treated myself as I would a patient. So okay, how are we going to modify this activity to make it doable? So I started life hacking the heck out of my bathroom, and electric toothbrush. And instead of holding my arm up to brush my teeth, I propped my elbow on the counter and brought my head to the toothbrush, which was electric. So then I wasn't doing this. And that made brushing my teeth that cost a whole lot less energy. The same thing with doing my hair, of course, right in the military. For females, if your hair is really any longer than about here, it has to go up. So I rocked the bun, and that was very, very hard to do, because holding my arms up like this to try and put my hair up in a bun, it felt like I had done tricep presses for an hour. It was just burning. I propped, and I did not want to cut my hair. So I, figured out a way to kind of prop my arm up on the wall so that I could hold it up, do my hair. So things like that. I have a wonderful friend and colleague who's an occupational therapist, and So if I think PTs are good at life hacking, occupational therapists are the masters of it. They will find a modification and a piece of equipment or device for anything. And I was talking about having trouble with work because I'm just typing at a keyboard. It was fatiguing my arms out. And she asked me, she said, "Where's your pillow?" I said, "On my bed." She said, "Well, go get it." And so I started putting a pillow in my lap, and that allowed me to prop my elbows on the pillow and type without having to use this lovely muscle called the deltoid, which fatigues out. So just things like that, right? So I really took I treated myself like I would treat a patient and say, okay, we're still going to do these activities. I'm still brushing my teeth in the morning, right? We just need to figure out how it's going to happen in the context of MG.
Thank you, Liz. It certainly sounds like there's potential for big differences from those little changes you suggested. Amy, when you first had to make certain adjustments to your self-care routine in order to work around your MG symptoms, did you experience any emotional challenges due to having to change the way you do things? And if so, how did you overcome it?
So I want to, I suppose, amplify what Liz was sharing. And in thinking about the physical limitations that come up with MG, and just going back to those basic everyday routines, I deal with the arm weakness she's talking about. It's one of my weaker areas. I mean, I feel like my muscle groups all take turns deciding who's going to be the top dog and give the most trouble on any given day. But what I'll do is you know, having learned like through doing physical therapy because of MG, how to use either adaptive devices or use my environment, what's around, to help prop me up. So I'm going to give you a couple examples. One is to brush my hair, and I don't have much, but to do it, I need to prop this because I'm right-handed, clearly. So I prop my arm up against my door frame and like kind of lean into the door frame. So my body's braced up against the door frame and it's holding me support, right? Then with the right hand, I can start brushing, brush. And even like that, there goes my arm. It's going to drop. It's inevitable. And so I wait, you know, let the arm fatigue, let that burning sensation subside, and then back at it and then finish what I'm trying to do. And I have that general approach, even, you know, to take a shower or something like that. If, you know, if I'm able to not use a shower chair, great. You know, if I need to balance, have those shower bars. Like I'm all about that. Adaptive technology, ways of utilizing what's around us in the environment to help us do things better and to take pressure off of our physical bodies and what we have to do. But also keeping it real, it gets frustrating, right? Having to always be adapting or having to be spontaneous when you possibly like being organized or like want to follow through with all kinds of things. You know, it takes a lot out of us, I think, as MG patients emotionally, right? It's draining, it's exhausting, it's frustrating. I want to be able to be consistent. I want to be able to continue to be relied upon. I want to have the ability, even just thinking about just like a minor segue, and we'll come right back, but even the world of work, right? To be able to hold down a regular job and have MG. How? If you're really symptomatic, how do you do that? I could start out at the computer, right? Even doing what I'm doing now with my own company. And I start out typing like so, body straight, right? I'm holding myself up for now, for this panel. But the lean is happening. You haven't noticed the lean in, the creep of the arms to the table and the hunched over because my muscles don't want to hold it up, right? Like I'd like to stay like this, have posture. As a trained singer, posture is everything, diaphragm in full effect. But MG is like, no, I'm going to take you down. So I like to use my adaptations. And something that I learned in having MG, and especially going back to how it affects my physical appearance and that tie in with self-esteem, physical appearance, it goes together for me. And as we shared, probably for a lot of folks in the room. So I'll use improvised ways, right, to do my makeup. And it comes back to physical therapy components and occupational therapy components. I feel like those are huge resources for us within our healthcare community that are awesome to take advantage of. Also want to throw in, I don't know that I've heard it mentioned per se, but home health care. Yes, home health care aides. Does anybody have one? A home health care aide, an attendant, or like a caregiver that assists them with doing daily tasks or chores, or going to the store for them, or laundry, or going to pick up prescriptions? Anybody have anybody that's doing that for them? Possibly a family member, a spouse. So, you know, utilizing our support system is huge. It's important. And those of us that may not have that support system, maybe you don't have a spouse anymore, or somebody, you know, in your immediate circle, home health aid care is something that can help to do those daily tasks. Because guess what? For myself, I have one 3 times a week. Looks are deceiving. You know, you sometimes see me in my energy mode and MG is calm and I'm not too sloth-like, and you're like, oh, she's moving pretty quick. Oh, she's not using her cane at the moment. Huh. And then an hour later, you see me, I'm like, hey guys, I'm great. You know, it varies. But coming back to those improvised ways, right, of adapting and thinking of ourselves in a positive light. You know, I just want to bring it back to how we empower ourselves. And for me, it really comes back to some of the terms that I've heard my MGers. I feel like we're all in sync right now in our conference about having hope, right? And believing in ourselves, in our capabilities, accepting that, yes, we have these different ways that we're impacted by MG that are challenging, but it doesn't make us less than. We're not just MGers. We are human beings with wants, needs, desires, and ways of living just like any other person. But we are special in our MG community. We truly are. I feel like we are, you know, connected in our unique way of having to adapt in this world. And we have each other to rely on. So, you know, remember, you have your community behind you. You have a huge healthcare network. Not just, you know, we have our neurologists, other specialists, we have physical therapists, and we can turn to them for support. And, you know, the same goes for the emotional component of all that comes up, because as I mentioned a ways ago, you know, stages of grief, coping with that experience of loss that we don't always recognize, that comes with chronic illness, that comes with rare disease, right? So in trying to work through that, for me, therapy, a coach, a teacher, right? People that can help us process things. So just something to think about. I'm going to give it back to you, Jen.
Thank you so much, Amy, for sharing your experiences with us. It's really helpful. Seth, what kind of self-care techniques have you discovered in dealing with the physical or emotional challenges due to MG?
So as you guys know, we all talk about the fatigue, right? So I have this running joke with my staff and myself, and you don't have to answer this question, but did you make your bed today? So we're on a hotel, so we don't have to, right? But that joke actually happens only because I always like to show that if you do your bed today, you're going to have a good day. So you have to set up your day straight. So one of the things that actually makes me to prioritize my self-care is empowerment. So while I'm actually doing my bed, I'm actually listening to empowerment to ensure the day is going to be running smoothly. What's going to be on the right direction? I'm going to have a positive mind. No matter how droopy my eyelid will be, I'm going to be happy and I'm going to be positive because I made my bed. So, and another thing that I do on the side is definitely to kind of keep myself going and zen, I guess we can call it, is meditation. I like to go ahead and take some time, whether your meditation might be listening to the most craziest rock band, that's mine, or you could actually just take some yoga. Meditation's my go-to for self-care. And I strongly recommend it to go ahead and have your own type of care for you guys. Back to you.
That's wonderful. Thank you for sharing, Seth. Overcoming challenges such as the ones Amy and Seth shared is one of the driving purposes behind the More Than MG campaign. Like just how little things, little changes in prioritizing your self-care can make a big difference in how you feel. The same is true for your physical and mental health. I'd like to turn our attention toward Liz for a few minutes. Liz is a physical therapist specializing in orthopedic and chronic pain conditions with personal experience with myasthenia gravis. But before we get into ways to take charge of your physical and mental health, Liz, I'd like to ask you, what inspired you to be here today and support the MG community?
Thank you, Jen. So first of all, it's an absolute honor to be here and to be able to talk. I guess the biggest thing that really inspired me to get into advocacy, and specifically here today, is to make sure that our community has a voice. Because, you know, a rare disease a lot of time gets overlooked because, you know, statistically there aren't that many of us, but I mean, look in this room and then of course on Zoom too. Just attending this conference, we are all over the place. And, you know, we are just as deserving of care as people with conditions that are more prevalent. So I wanted to make sure that that my efforts, both personally and professionally, are helping to give our community a voice and get us the care we need.
Since a primary symptom of myasthenia gravis is muscle weakness, physical activity is often more of a challenge. Before we move forward, could you explain the difference between physical therapy and occupational therapy?
Move forward. I see what you did there. So yes, before I mentioned physical and occupational therapy, and I do get this question a lot. Now, first of all, we do have a lot of professional overlap. So physical and occupational therapists are both movement specialists. We just focus on different kinds of movement. So your physical therapist is going to focus on the bigger movement, the bigger muscle groups. So these would be strengthening, working on endurance. This would be working on your balance, mobility, walking, core stability, and those sorts of activities. Occupational therapy is going to work on more of the smaller muscle groups and more of your fine motor skills, or specific activities of daily living. So if you're thinking of anything ending in ing, dressing, grooming, bathing, eating, you're probably thinking occupational therapy. That being said, their PTs will address things in the OT realm and OTs will address things in the PT realm, which is why we work really well together. A lot of times we do co-treat. I like to use the analogy that if you're in the hospital, your physical therapist will get you walking down the hallway. The occupational therapist will make sure you're dressed first.
That's awesome. Thank you for that explanation, Liz. Now, could you talk about what exercising and moving your body have done for you?
So as I said before, right, part of the treatment regimen, and which is different for everybody, but there's medication. There's, of course, resting and making sure we're taking care of ourselves and doing energy conservation strategies and pacing and all of that. But then there's also movement. I think it's a common misconception that in myasthenia gravis that all movement is bad or all muscle contraction is bad, but that's absolutely not the case. Every single one of you is using muscles. Otherwise you'd be on the floor like a pile of goo. So which it feels like that sometimes, I know. But right, we have lives. We have things that we have to do. We have things we want to do. And all of that requires movement, not to mention the very, very well documented health benefits. So if you go on to CDC, World Health Organization, any of those sources, you can find a laundry list of the health benefits of movement and the effects of not moving, of not having regular activity. So right, the number one chronic disease in the United States is heart disease. And one of the biggest defenses we have against it is exercise and movement. However, with MG, right, it's not that it can't be done. It's just, we have to do it like everything else with this condition. We have to do it a little differently. And so that's been really, really important for me because there's still things I want to do. I have a 5-year-old and a 3-year-old, and I promise you, I have to move. And I want to move. I want to be able to, they're going to do their spring festival, and they're going to go hunt for eggs in the yard. Right. That's, I want to be out there with them. I want to be able to do that. That gives me meaning. I also have 2 dogs, and they're terriers. They move too. So being able to have that is very important to me. And also being able to professionally, that's one of the honors that I've had working with the MG community in a professional capacity, is being able to help people restore their own movement and learn what they can do. Like I said, with PTs, I'm hardly ever going to tell someone you can't do it. I'm just going to say, okay, it might look a little different, but we're going to figure out how you can do it and modify it. And so that is both personally and professionally, movement has been a huge thing for me.
Yeah, that's very inspiring and great, fantastic advice, Liz. By raise of hands, how many of you out there have a hobby or activity that you enjoy doing, particularly any physical ones? By another raise of hands, how many of you find that those hobbies or activities are small things that make a big difference in your lives, such as making you feel self-empowered? Amy, do you have any hobbies or activities that you love that help to increase the general physical activity in your everyday routine?
Absolutely. So I am a person that enjoys a lot of different hobbies, and stemming from doing training in different fields in the arts, particularly. I'm a classically trained vocalist. I am a visual artist, and I love to dance. Even if I don't particularly dance great, I can hold a beat, and I can still move my body. These hips can still whine. So I've got a fun time. For me, singing is part of everyday life. Anybody that's been around has possibly heard me, and collaborating with some other MGers that are also classically trained vocalists. And we've been heard singing in the lobby. You've missed a concert if you weren't there, but maybe there'll be a recap.
Steph, do you engage in regular physical activities or hobbies?
I'm actually a roller coaster enthusiast. So I love roller coasters, and I love taking that stroll around the side. So definitely those are my hobbies. But then I just kind of go back, and as easy as it might sound, you guys can probably see the prompters. There's the pictures there. So shout out to the More Than MG campaign. But selfies, guys, is actually something that I love to do as a hobby. I like to bring people into our reality, right? I want folks to understand that we are the same. We're out there. We're the snowflakes, right? So definitely, and you might think, why is the selfie a hobby? Because we talked about the weakness in muscles. We talked about how all of that is actually a little help there. So that's a little thing that will make a big difference. Taking that little selfie, get that flexibility going, that muscle going, and just create muscle memory. So those are my crazy, fun little hobbies there.
Thank you both for sharing the things that seem small but make a big impact in your lives. Liz, based on your personal experiences and what you've seen some of your patients do, what are some of the more creative ways to incorporate more daily physical activity?
Not medical advice. Start low, go slow. So start with just something simple, something you enjoy doing, whether that's walking, whether that's, playing with the dog, whether that's dancing right there with you. Although I'm a Texas two-step girl, so in my kitchen, but just those little activities, just do a little bit. And then of course rest, don't kill it. But just to find those little ways to incorporate those things that make you happy.
That's awesome. Any final advice for individuals living with Myasthenia gravis before we move on to our Q&A?
Give yourself some grace. So your body is working so hard for you, and you've got this, and you've got a fabulous support network around here. So yeah, so show yourself some love.
Thank you so much, Liz. Before we hop to Q&A real quick, I just want to thank these guys. You guys did a fantastic job. I think it was a great way to end the day. Yes, please, all the love for them. You know, we started the day with a message that follow the mind and the body, or, you know, take care of the mind and the body will follow. Take care of the small things and everything else will fall into place. So again, another round of applause for these guys. Do you want to do Q&A? Do you want me to run around? Do you want to race? No, I'm kidding. Go ahead.
First of all, once again, I'm Dr. Mack. I'm actually a senior medical director at Genentech, which is a Roche company. And there's quite a few people here from around the world who are here to meet all of you. And I just wanted to say, this is a room filled with so much beautiful courage. It's hard. And when you don't have anything, you don't know what to do next, all you can do is dig deep and find that courage and people around you to help lift you up when you need to take the next step. So just want to say thank you all for sharing so much, all the work that you at the MGFA, the work that you've done and all the people who are here. Thank you so much. And one quick question. Do any of you feel that you have any, when you're feeling fatigued, any cognitive changes that you feel occur?
What was that question? Can you repeat your question one more time? When you're fatigued.
Actually, I have not had any of that experience. And like I kind of mentioned in the beginning, I'm a call center manager and I manage over 2,000 employees. So no cognitive issues. So very, very excited. I know it might be different for others, but for myself, I don't experience that.
I do experience fatigue. It comes in waves, kind of like a tsunami wave where it just whoosh, knocks me down. And it stops me in my tracks, the fatigue. Specifically, not particularly the cognitive issues, you know, but I do understand that feeling, that sensation of a brain fog, you know, or feeling fuzzy, feeling maybe like a little confused because I'm overtired or that, well, not really tired. The fatigue for me, I could sleep and sleep and sleep. And sometimes it's just not enough. And I actually have taken that particular symptom, right, and run with it with every specialist that I have. And I have all kinds of specialists, neurologists, rheumatologists, hematologists. I have other health issues. So there's a collection. I have a healthcare team. And I feel like for me, and this goes back to me in music, right? So I am the conductor of my orchestra. I have my first chairs for each department, right, that represents whichever health issues or symptoms that particular department's in charge of, right? And so I worked with them to address the fatigue because I'm like, is this something that has to do with endocrinology? Is this hormone related? Is this MG related? Is this other condition related? You know, there was a lot to look into. And the bottom line is, we still don't know. Welcome to the world of uncertainty in rare diseases. Thank you for coming. So, you know, I would say that for me, you know, and I think typical with MG, you know, cognitive issues can come up for folks for a range of reasons. And I am not a doctor. I don't have medical advice for you, but I would say if you are suffering from fatigue or you find that you have cognitive issues coming up, talk with your healthcare team, talk with your neurologist, talk with your PCP and you know, work with them to kind of analyze the symptoms, analyze life, see what's going on and come up with a plan to address it.
Thank you so much for that, Amy. I hate to cut off the Q&A time, but we do know the importance of having fuel as well as rest. So right now at the back of the room, we've got some snacks prepared, and then feel free to take a couple of hours to rest and decompress so that you have a little bit more energy for tonight for our Mardi Gras party happening right here at 6:30. Thank you all so much. Let's give a warm round of applause.